So with that, here's your program agenda. For the sake of time, I'm not going to go over it, but I'll kind of walk you through during the break times and whatever. And I'll go forward. We'll start with our first speaker. We're really thrilled to have with us all the way from Washington, D.C., a good friend, Susan Dentzer. Susan is now the CEO and the exec at NEHI, which we used to know as New England Healthcare, right? Now it's Network for Excellence in Health Innovation. Okay. And Susan, you also might recognize her name, her face from she does a lot of moderating at national conferences, international work, and was formerly the chief person who was responsible for a lot of the work that we got published in Health Affairs when she was in that role. So Susan.
Thank you so much, Marie, and good morning to all of you. It is great to be with you, and it's finally fall in New England, so timing is perfect. And as Marie said, we got to know each other when I was editor-in-chief of Health Affairs, and she published a really wonderful article with us on pharmacy in the patient-centered medical home. And we've been good friends ever since, and I was just thrilled to get the invitation to come up and be with you here. Everything you just heard Marie talk about in pharmacy is so critically important, and what I'm going to be talking about today is how all of that fits in with the future healthcare delivery system that we see evolving. My organization, NEHI, is a cross-sectoral group of people from all the various different sectors of healthcare. So we have provider systems, payers, patient groups, biopharmaceutical companies, et cetera. And what we do is take on projects that we think are going to advance triple aim goals of creating better individual and population health, better quality of care, and lower cost. And as we surveyed the terrain in the past year, it became obvious to us that there is a very important amount of innovation going on right now that is largely related to the here and the now. And then, to take that cue from one of Marie's slides, zooming out, if you zoom out, you realize that there is a much more, I don't want to say important because it's all important, but probably a much greater amount of structural innovation going on that is driven from outside the healthcare sector, largely by the technology sector, and those forces are going to come to bear on the healthcare delivery system over the next decade. So that's what I'm going to be talking about, and I'm going to ask you as I go through my presentation to think about how pharmacy fits in to the picture that we see evolving, because it isn't clear how it's going to fit in, and part of it will be up to you all to figure out how to structure the system in the future to make it work. So our project, let me make sure I can advance here to the right slide. Not yet, but I'll keep talking till we get the slides up. Our project is called Healthcare Without Walls. And it's a little bit of an overstatement because we don't think all the walls in healthcare are going to go away. But what we do think is that healthcare is clearly moving out of what we used to think of as the traditional settings in which healthcare was received, hospitals, physicians' offices, even to some degree pharmacies, and that it is moving now to a much more distributed set of exchanges. And if you take the aspects of healthcare that do not involve actual laying on of hands, that really are about exchanges of information, those exchanges of information will increasingly occur in virtual settings, just the way most of our lives are taking place now. I wouldn't say necessarily most, but much of our lives takes place in a virtual setting. How many people here buy a lot of goods online, for example? How many of you feel, as a friend of mine feels, that a day without Amazon is like a day without sunshine? So that is the world that we're living in most of our lives, except for when it comes to healthcare. And as Bernard Tyson, the CEO of Kaiser Permanente, says, he asks his people, what if you didn't have to step out of the 21st century to deal with Kaiser Permanente? And it is a great way to frame the issues before us. What if you didn't have to step out of the 21st century to access health care? That really is the fundamental question. So I guess we're still having some difficulty getting up my slides, so I'll just keep talking, and I'll catch up. The slides will catch up eventually. So zooming out, we began to ask, what are the forces that are driving this movement toward more distributed health care? If you look, for example, at statistics about hospital inpatient utilization, the trend line, I'll mimic my slide here, has been going like this, right? So we know care is drifting out of inpatient hospital settings, and we know the commensurate slide is what's happening in the outpatient setting, and that's going like this, right? So we know care is moving out of inpatient to outpatient. We know that there's increasing need to focus on the needs of individuals in their homes or communities. We know that the social determinants of health are very important drivers of health status in life. So understanding people's social context, their level of income, their level of education, et cetera, is very, very important. And most of that is stuff that's happening outside of the healthcare setting, right? That's where people live their lives. So increasingly, we need to understand that. Are we having
technical difficulties? However, as a backup, and I know Susan is a good person to have this happen to. Sorry, Susan.
No problem.
We're going to use the slides that you've got in your book. So they start with Healthcare Without Walls, and so we can hopefully keep you on track from there.
Okay,
yeah,
terrific. So we know we need to focus more on the needs of people in their home and communities, and we know that, for example, we still have the Affordable Care Act in place. More people are becoming insured. We also know the population is growing, and of course we understand the need that we're going to have to move to more new payment models and all of that in order to deliver care effectively at lower cost. So all of those forces are impinging on this need to restructure healthcare. So let me start then with a story. And look at the slide. It'd be hard to see. It's much better in color, I assure you. There's this guy who looks like he's fishing in a river. So I'm going to ask you to imagine for a moment a fellow named Dave. Dave is in his 40s. He's a natural scientist. He happens to live in Kodiak Island, Alaska. Has anybody ever been to Kodiak Island? A beautiful spot, isn't it? Very remote, but a beautiful spot. So Dave is working there as a scientist, and he's a very healthy, outdoorsy guy. You can see him in this picture fishing. So Dave develops a cough, a nagging cough that won't go away. And after a couple of months, he's a guy, he's not going to rush this healthcare thing. He takes himself to the critical access hospital on Kodiak Island. There's one, Providence Hospital, a 25-bed hospital, several primary care docs, a couple of specialists. It's not a big facility. He has a workup. His doctor gets worried. He has some imaging done, and they find a tumor in his lung. And they tell him that based on his history, they have a suspicion that he's never smoked, that it could be non-small cell lung cancer. So Dave, being a scientist, goes home, gets on the internet, reads everything he can find about non-small cell lung cancer, decides that there's a very important program treating non-small cell lung cancer. It happens to be at Memorial Sloan Kettering in New York City. So he decides he's going to reach out to the clinicians there and figure out what to do next. So he does. He sends them an email, and you can see the picture of the clinicians grouping there together to think about him. Now, what is Dave's alternative once he has established contact with the physicians at Memorial Sloan Kettering? He can either get on a plane and travel the more than 3,000 miles to New York City. He can have a workup. He can get a nice, $400 hotel room, stay overnight for a bit, get his workup, get a therapy plan agreed to, and then what? What does he do? Does he move to New York? Does he stay there? Does he get his treatment there? What does he do? That would be one way to think about the world, and the world is as it is now. But let's think about a different world where Dave decides that as we know increasingly, it's important to get your genome of your cancer genetically sequenced, so we understand the actual molecular pathway of your particular cancer. He knows that could be done. He knows those results could be sent to Memorial Sloan Kettering. He knows his images could be sent to Memorial Sloan Kettering. He could have a telehealth set of communications with the clinicians there. They would then turn and consult their artificial intelligence backup. They're working very closely there with IBM Watson to scrutinize the literature and decide what an appropriate treatment pathway might be for Dave. They could decide on that. They could communicate via telehealth with Dave. And then they could order up a new targeted therapy drug that has come on the market in the last couple of years and have that sent to Dave, dispatched from a specialty pharmacy in Seattle, and delivered by drone to the critical access hospital on Kodiak Island where he could be infused with it. So that would be a different world. Now let me ask you, what of that technologically could not happen today? Any ideas? Sorry? Great. Good answer. The only thing that couldn't happen today is the drone, because there is not currently drone service between Seattle and Kodiak Island. But there will be. And so you don't even really need the drone, because you could also dispense that and have it delivered by FedEx, right? So the drone is not that material. But could any of the rest of that happen today, technologically? Every piece of that could happen today, technologically. Now let me ask you a different question. Would any of that happen today? No? Yes?
I think it depends on the person's insurance. Well, their persistence also to see that it happens, and willingness to overcome barriers along the way.
That would be a good world if it came to that. Actually, from a standpoint of the healthcare system, almost none of this would be able to happen today for various reasons. Regulatory, right? Telehealth across state lines, unless Alaska is part of a multi-state compact. They couldn't do the telehealth, the reimbursement issues, the payment issues. You know, there's no payment model that allows for that kind of care. You know, there are all kinds of barriers standing in the way, none of which are technological. So that leads us to start to think about, let me ask another question. If you were Dave, would you want this to happen? Is this how you would want your care to be delivered? No? Yes? Yes? Okay. Was somebody shaking their head there? No? Okay. So yes, and why would you want that? Because as an individual, we want the best care available, right? Is there any reason why you should not have the best care because you happen to live on Kodiak Island instead of New York City? Okay, great. Great, okay, so there's the hospital. Okay, let's see. Is this not working? Okay, there we go. So moving on. All right. So, of course, we would want what Dave idealizes he could have. But this is what we have today, right? We do not have a system of healthcare without walls. We have a system that has a lot of barriers to accessing care in the way we could receive it. We have a system that is really riddled with friction for people, like having to get on a plane and travel 3,000 miles if you want the best health care, et cetera. And so we know that this is not going to be sustainable, our current system, over the long haul for several reasons. And I mentioned earlier what some of these factors are that are going to drive care to more distributed settings. The move from new payment models that are pushing us from volume to value, the need to move more upstream and to address some of the issues plaguing the population that are predisposing people to poor health, the innovation that's underway already in care delivery, and of course the technology. So let me just quickly walk through the forces that we know are playing out. We know that there's a movement to greater retail delivery of healthcare. This is why we have minute clinics and CVS's and new pharmacy arrangements in Walgreens, et cetera, et cetera. We know that right now that is not displacing a lot of care that shows up in the emergency department. For various reasons. We're trying to understand why that's not happening, but we know it could happen. We know that these settings could engineer more care delivery, and we know that the people behind them are thinking about that. So, for example, CVS is now starting up pilot programs to do telehealth from people's homes into the minute clinics, and then also telehealth from the minute clinics to other settings. So that, for example, if you come in for what you think is a non-urgent situation and the nurse practitioner at the clinic thinks, maybe we better get a consult with somebody else, they can, instead of just telling you to leave and go to the ED or something, they can actually do an online telehealth visit with a clinician in another setting. So they are working on making that kind of transition possible. And that increasingly people, because they like the convenience of the Minute Clinic experience and related clinic experiences, and because they like the price transparency, they know because the prices are posted generally about what it's going to cost them, that we know that this movement is going to build over time. We know that if you look online, in almost any aspect of healthcare delivery, you will find increasingly telehealth delivery platforms evolving. We know, for example, that the online pharmacy has been on the part of the landscape now for the better part of 15 years. We know, for example, before the Medicare drug benefit was enacted in 2003, a lot of seniors were buying their drugs online from Canada, right? So we know that that's been in the environment. But you can also see now online psychotherapy in the middle there. You can also see basically online vision tests now and online ordering of eyeglasses. Now, is it utterly the same experience as going to the optometrist and getting fitted for your lenses? No, but does it work pretty darn well for a lot of people, and is it a whole lot more convenient? The answer is yes. So we know that this is already starting to become a feature of the environment in many, many settings outside of pharmacy. However, it's also becoming an issue in pharmacy. This is just an example of a guy up in Ontario who was working with a 30-bed, some really small acute care hospital, as you can see there, serving mostly Aboriginal peoples in that part of Canada. A hospital could not recruit a pharmacist to come to this small hospital, so this remote pharmacist, Kevin McDonald, began doing it from his home, essentially, in a different city. And guess what? It worked. So they then extended that model to several other cities, as you can see in Ontario and Saskatchewan. And now he runs his own telepharmacy company, Northwest Telepharmacy Solutions, to bring this to other parts of Canada. So we know that we already have, in effect, proof of concept of how this is working. Now, many of you will know that telehealth services do exist currently, and one of the biggest ones is run by this company, Teladoc. Out-of-pocket charges for a visit are $45. A lot of self-insured employers are turning to this model now, particularly for their employees to use on the weekends, because what employers don't want you to do is get sick on the weekend and take yourself to an ED, where what could be a $45 telehealth visit becomes a $1,500 workup in the ED, right? So these kinds of services are slowly picking up steam throughout the country. The telepharmacy capabilities are starting to emerge. There are multiple different types of them. As you can see, you have, for example, on the inpatient side, remote order entry review, where, as you see there, a remote pharmacist reviews medication orders before a hospital staff administers them. So that's kind of using a backup service in effect. You also have things evolving where a remote pharmacist is preparing IV solutions for hospital pharmacy. You have increasingly retail telepharmacy developing, and also remote counseling going on by pharmacists, both through telehealth and video conferencing, either with the physician and a patient in a separate site or directly to home. But this is all starting to come about. And we know there are many other factors underway. Uber has a health division now, Uber Health. They started very small with a pilot, particularly in Boston, where if you had 10 people or more, you could call up Uber in Boston and say, we've got 10 people here who want flu shots. They'd put a nurse in a car, come in an Uber, come to you, I'll give everybody in the office flu shots. And they are rolling out a doctor-on-demand service in many parts of the country. Lyft is doing similar things, and in fact, CVS will soon announce 8-hour prescription drug delivery via Lyft in many parts of the country as well. And basically, Blue Cross and Blue Shield Association basically now is also partnering with Lyft so that their commercially insured patients who don't have transportation can actually be taken to physicians' offices. And of course, you could presume that that would also be possible to take them to pharmacies as well, and that's probably coming also. We know that a lot of people believe that the most important medical instrument devised in the last 10 years has been the smartphone. And it's not so much because of what smartphones are today, but what they could be. So for example, you can have your smartphone equipped with essentially an echocardiogram reader device, as, for example, does Eric Topol, who's a well-known physician and technology maven out at Scripps in California. He says, why does anybody use a stethoscope anymore? That's really an obsolete technology. Everybody should have, instead of a stethoscope, a echocardiogram-equipped cell phone. You can have cell phones now equipped with ultrasound, remote ultrasound. You could theoretically have a newly pregnant woman come in for one visit, send her home with a handheld ultrasound device, and basically not have her come back for a visit, except for maybe once or twice toward the end of her pregnancy. Eric Topol's own daughter, who was pregnant recently, had a handheld ultrasound device, and Eric said the only problem was she wanted to use it about 4 times a day, just to make sure everything was going all right. But so all of this is possible. Drones coming. UPS has a drone, is developing a drone delivery service. Amazon is developing and investing in drone delivery services. There was a test done about a year ago up in the Boston area where they put a bunch of medication on a drone, flew it from Boston across to Beverly, Massachusetts, across the water, delivered it to a summer camp for children, proved the concept that could be done. So we know, within 5 years, we will have drone delivery of medications in particular, especially in remote settings where other forms of transport are more difficult. Artificial intelligence is coming online. As many people will tell you at the moment, artificial intelligence is not that intelligent. It is basically very useful for processing structured data and routine data. It's not very good at picking up on context and subtleties of human speech yet. Does anybody here have an Alexa or an Echo or whatever? So you can say, Alexa, what's the weather today? It can process that. If I said, Alexa, give me your analysis of Goethe's poem, it can't do that, right? But it can do structured kinds of processing of data and responses. Radiological images, a case in point. Most people believe that there's this notion of the Pareto optimal, about 80% of everything looks the same and the variation is only in the 20%. Well, it turns out that's true of most radiology as well. So for 80% of images, those could probably be read as effectively by a machine, a learning-enabled machine. better than a radiologist. And in fact, that's going on in many parts of the country now already. Lots of machine-enabled radiological readings going on. So that means you could have human beings focus on the really hard 20% of scans, and the rest read pretty routinely by machines. So this is coming. Digital health explosion, as you see, taking off. Eric Topol, again, I'll mention here, talks about the huge array of remote sensing devices that we now have the capability to have in people's homes, for example. And that and the so-called Internet of Medical Things, which is sort of the notion of internet-enabled devices in the home, we're not talking about people wearing lots of Fitbits. We're talking about devices, sensors in homes that basically we're on track to have about 50 billion of those connected devices globally by 2020, an average of 6 or 7 devices in people's homes that are collecting data in various categories, and in categories we didn't used to think that we needed to collect data in, about people's environments, their interaction with the environment, about their genome, et cetera, et cetera. So that's going to create the opportunity for vastly more acquisition of information about what's going on with people, and therefore more predictive analytics about what that's going to mean for their health. So let me skip, in the interest of time, since we got a little bit delayed at the start, to talk about Amazon as the sort of quintessential disruptive force here. If you think about the categories of commodities that are commonly purchased, there are, believe it or not, a list of about 28 of the most widely purchased commodities. Amazon already distributes 27 of them online. There's one left that they don't. I learned this from my friends at CVS, pharmaceuticals. So guess what Amazon is gearing up to do? About a year ago, they launched a 1-hour delivery service for non-prescription items out of a Seattle pharmacy. Then they turned around this year and hired a guy to create an internal PBM for Amazon for its employees. And now they are working to start up a mail-order pharmacy operation. This is part of the reason why CVS is now gearing up its own online pharmacy operation and also its delivery. And I'm getting nagged to stop here, so just give me a couple more minutes here, again, since we got a little bit delayed at the beginning. I'll close with this example of technological disruption that I think it's important for people to understand as we think about what is coming into healthcare more broadly. Here's how Amazon looks at the world. They look at everything that they do in terms of a value chain. What does that mean? They think about what in any enterprise produces value. So they look, for example, at book publishing. And many of you will know that Amazon now does its own book publishing. They publish ebooks. You can buy many books, obviously, on Kindle, et cetera. And when they looked at publishing, they said, where's the value come in publishing? It comes because authors write books and readers buy them and read them. And everything else in the middle is an attempt to chew away at the value. So you've got on the one side the authors, the readers, consumers. Literary agents will then take a book and try to sell it to publishers who take a cut. It then goes to wholesalers and distributors who take a cut, and then it goes to bookstores who take a cut, and then it goes to the consumer. And so Amazon said, why are all these people taking a cut? Let's just start up an e-publishing business. So in effect, that's exactly what happened, and as a consequence, Mark Weir, some of you may have read the book or seen the movie The Martian. Mark Weir wrote The Martian, took it to 13 different publishers, all of whom rejected it, self-published it on Amazon. In 3 months, it sold 30,000 copies. Crown Publishing then woke up and said, maybe we shouldn't have turned this book down. They bought it back. It then ended up on the New York Times bestseller list. It turned into a major motion picture starring Matt Damon, and now Andy Weir doesn't have to work a day the rest of his life, right? That's how Amazon looks at the world, and that is how the tech sector is now looking at healthcare and saying, what's contributing the value in healthcare? What stands between the patient and the clinician that is not achieving value, that is just about adding cost, greater friction, et cetera, et cetera. So I will close with this, and the rest of my presentation has some examples of how various entities are taking baby steps into this arena. But there was a letter recently published on this website, quartz.com, from a professor at George Washington University, and he called it an open letter to Jeff Bezos, who's the head of Amazon, of course. We need you to do to healthcare providers what you did to book publishers, to bookstores, brick and mortar retailers, challenge their old ways of doing business. And he basically cited as his rationale, he pointed to an investigative series that the Chicago Tribune did last year, where they sent reporters to 255 different pharmacies, and they tried to fill prescriptions for 2 drugs that, taken together, were contraindicated. And these reporters found that in more than half the cases, the drugs were filled and they got no warning that they were contraindicated. So that speaks to the problem that Marie identified, right, in medication management that we know is rampant and is probably at least as big a problem as adherence or lack of adherence. So these are the kinds of problems the tech sector is looking at and saying, how can these things happen and how can we bring our disruptive capabilities to bear to redo healthcare so this doesn't happen? And the invitation now that Professor Etzioni makes is the invitation I would make to all of you, which is what can you do to take advantage of these new technological capabilities to eliminate what we want to get rid of in healthcare, push toward better quality of care, push to more convenient care and access models that probably would not only be better for all of us, it would democratize the knowledge that we have, the state-of-the-art knowledge that we have about how to do things right, and really deliver on the goals of getting the best care to the right patient at the right time. So with that, thank you very much, and I apologize for the little technical difficulties, but enjoy talking with you, and I'll enjoy engaging with the rest of people as well.
So actually, the apology isn't something that Susan should talk about. It's on our part. So thank you, Susan, for being very flexible and ad-libbing and those sort of things to keep everybody calm by the time we got to your Kodiak slides or whatever. So next, Mark Schaefer's going to talk to us about the Connecticut SIM program, where he directs the project management office.
Well, good morning, everybody. It's terrific to be here, and if that wasn't a VUCA presentation, I don't know what would be. It certainly overwhelms with complexity and value opportunity. I'm going to talk about the State Innovation Model Initiative, which Lieutenant Governor Nancy Wyman's been leading since, I think we started this work back in 2012, 2013. I'd like to start, we've done a tremendous amount of listening over the past 3 or 4 years to try to hear from consumers the kinds of problems that the challenges they've faced, and also the kinds of solutions that innovators in the community-based organization community and also in the healthcare sector have come up with that are instructive in thinking about the kinds of reforms we want to accelerate under SIM. So I'm going to begin with Khan. Khan is as you can see, an Asian American woman who I met a couple of years ago, and she told a story about that happened about a decade ago, in which she was raising 7 kids on her own. Her husband had left her. She was working at a print shop, and she was managing okay, and she got into a car accident while she was driving with her oldest son, who was fine, but she had a minor head injury, was taken to the emergency department, and she began to get engaged in the care process, ran into some communication problems, was anxious for reasons that the medical team didn't understand, and she ended up leaving against medical advice, going back to her home and family, but had symptoms in the months that followed, and those symptoms, cognitive problems, led to her being laid off from her job, after which her finances, as you would expect, went down the tubes, and she wasn't able to care for her family. And she was, that resulted in a tremendous amount of stress, and she was found one day walking the streets, muttering to herself, confused, and she was admitted to the ED, became more agitated, was admitted to a psychiatric unit where she was, continued to be agitated, disorganized, confused. They thought she was psychotic. She was physically restrained. She was put on antipsychotic medications, and when she had stabilized, she was sent home. With some awareness, as I understand it, about her need for social support, so she was given some instruction about accessing social support, but basically after that was lost to follow-up. She returned to her family, struggled. It was evident to her neighbors when she talked about wanting to end her life. She was clearly in despair, and it was at that point that her neighbors were good enough to intervene by bringing her to the attention of a local pastor who made a connection that was really life-changing for her. When you hear that story, what comes to mind in terms of barriers to care? The only proviso to that question is that the one person who may know more about this patient doesn't get to participate, but everybody else can. What strikes you about this story, or what do you suspect might have gone on that might have led to a different outcome if the healthcare system had responded differently? Sure, both culture and language. Language was a big one, even though she could speak some English. It should have been apparent to the folks in the ED in the first hospitalization that she needed some translation services, and probably the second hospitalization as well, to thoroughly understand what was going on for her. Anything else come to mind? That's a great example. What's the hospital or health system's responsibility to ensure that certain essential aftercare needs are met to avoid the kind of outcome we saw, both with regard to her losing her job for lack of support and then ultimately being rehospitalized? Well, before we go to that slide, so language accessibility was a big deal in both hospitalizations, and in fact, she ended up presenting. So she was referred to a community organization on New Britain Avenue in West Hartford called Khmer Advocates, and she came in a confused, unkempt state, and connected with a community health worker and team there who really explored what was going on for her. And it turns out she's Cambodian American and had come to the U.S. as a refugee. She had a history of torture, losing family members to the Pol Pot regime, of being in forced labor camps. She had a considerable traumatic history that led to both PTSD and also depression. And as is the case when you're exposed to that kind of history, you're also at higher risk for certain physical problems, including diabetes and hypertension, and she had both. She was not actively in care for either of those. I believe that those problems were diagnosed previously, but she was non-adherent in terms of the medical care that was recommended. So, and I think, as I'd already mentioned, she was referred for social services, but really didn't know the first thing about how to go about doing that. Had profound implications for her care, and fortunately, she Let's go to the next slide. So fortunately, at Khmer Advocates, they have a team-based approach to care in a community setting that was accessible to her. And first and foremost, they had a pharmacist who could help her around counseling for her medication needs, and somebody who was familiar enough with the Southeast Asian community and the Cambodian community in particular to understand some of the superstitions or issues of trust around taking medication, and who could monitor the adherence and refills. I think a perfect example, you know, comprehensive med management for the deep end cases of people on 13 or 14 medications is one role of a pharmacist, but as you noted, Marie, in your own presentation, there's an earlier point an upstream point where the involvement of a pharmacist can be a light touch, but a critical touch in terms of patient care. They also had a community health worker who actually spent most of the time in terms of getting her back on her feet, established routines of daily living, arranged for interpretation services, and even helped her with some chronic illness self-management around blood sugar monitoring and blood pressure. There was a care coordinator who helped with long-term disability and arranging for hospice for her mother. And there was a mental health provider who worked on some of the issues of cognitive impairment and also helped provide exposure and grief therapy and helped her apply for citizenship. So things turned out really well for Khan once she was connected to Khmer Advocates. Her diabetes and blood pressure are under control. She's a behavioral health specialist. She knows how to access the services she needs. She has her feet checked every year, eye exam and flu shot. She had the strength and support to be able to support both her husband, who she got back together with, or her ex-husband, and her mother around their end-of-life care needs, and she is now active in the community teaching others about the importance of exercise and healthy diet. This story, there's no way this outcome could have been achieved without a community organization that had the resources and wherewithal and really understood this particular patient population. There's probably some 24,000 Southeast Asians throughout Connecticut, and for the most part, they are invisible to the healthcare community. Mostly invisible because the kind of data that would allow you to understand how well you're serving Laotian, Vietnamese, Cambodian patients is simply not accessible in the EHR. If you're collecting race ethnic information that would allow you to understand a population that you're not doing especially well with, it's probably just black, white, Hispanic, Asian Pacific Islander, essentially. So one of the things that we've really focused on in SIM is that idea of health equity. So that if you look up here, you see the main drivers that comprise the state innovation model approach. And I'm going to talk about the transforming care delivery and payment reform. With transforming care delivery, we've basically, in partnership with DSS, we're making technical assistance resources to providers that are getting into value-based payment arrangements with commercial Medicare and most recently the DSS Medicaid Shared Savings Program. And in that program we have comprehensive care management standards, we have health equity improvement standards, behavioral health integration standards, and also if you read down we have a set of standards around comprehensive medication management, and so we're doing a lot of direct support with providers to help them to develop the capabilities to do a better job with patients like Khan. Because I've only got 2 minutes, I'm going to spend 1 minute just pointing out that, if we can go back one slide, that one of our goals with working with organizations is to help them make the kind of connections with community partners in the health neighborhood, both healthcare and non-healthcare, to better enable them to get to deliver value. Now let's go ahead, if you can help me go up to just one more slide. Another one? Okay, stop here. So In order for health systems to embrace the kinds of innovations that are needed to deliver value for patients like Con and a lot of other patients who need a team-based approach to care, where most of the work of the teams is now reimbursable, is to migrate away from traditional fee-for-service modes of reimbursement to modes of reimbursement that are tied to value, control over the total cost of care, and delivering better outcomes more affordably. And the situation today in Connecticut, we began to promote total cost of care accountable payment models, shared savings program models, beginning in 2012 with the advent of the Medicare Shared Savings Program, ACO program. And the good news is that if you look at Anthem's network, you've got about 85% of the state's primary care physicians are in contractual relationships where they're accountable for the total cost of care and the quality of care. The bad news, and we have 15 to 18 organizations statewide that have organized to take on accountability. The bad news in terms of where we are today is we basically have not evolved beyond those 2012 models, which have a long list of limitations. Everybody is still, in Connecticut, crowded at the shallow end of the pool when it comes to payment reform. There are very few instances of downside risk. There are very few instances of global budget with upside payment that allow you to flexibly reinvent the way you do primary and specialty care. It's simply not happening. And in fact, the kinds of healthcare cost battles that you see going, there's a war of gargantuans that you've probably read about in the Hartford Current between a prominent healthcare system and a prominent payer. That's really an old market old market battle. It's a battle around unit cost, which has no tie to the value that the provider is giving. It's simply about the consolidation of market power. That's diagnostic of a problem that we have in terms of the evolutionary curve of our payment reform. And so what I would leave you with is that I think the single most important thing to enabling pharmacists to play the diverse role that they can play in care teams, whether from the position of a community pharmacy or more integrated in the way that Sean's going to talk about, is getting to payment models that put more money into primary care as a percentage of premium and do so in a way that's flexible, that allows the primary care system to reinvent itself, including the adoption of some of the innovative technologies like remote monitoring and telehealth and, you know, the long list of things that Susan talked about in her remarks. So I'm sure I'm out of time, so I'll leave it at that.
Thank you, Mark. And now we're going to have our last opening speaker, and that's Sean Jeffrey. Sean is a faculty member with us at UConn School of Pharmacy and is also in a jointly funded position that we have with the school and Hartford Healthcare's Integrated Care Partners.
Does that work?
Yep, it does.
Good.
Very good.
Okay. Thank you all. Appreciate the opportunity to be here, and my time is now ticking, so I'm going to make the most of it. So keep me honest here. First of all, appreciate again to be here and honored to be able to speak to you. I'm sure that some of you in this audience may have seen some of these slides, but hopefully the context is going to be a little different. Let's start with the things that we can all agree on. I hope the message resonates with all of you, or at least some of you, and the bottom line up front would be that medications have tremendous value, as the name of the conference states, as do pharmacists, as do all those involved in the prescribing, administering, storing, safeguarding, and taking of medications. However, the context is very important, right? So I'd like to start off with two statistics. And for those of you who know that my background is in geriatrics, this may not surprise you. But first, I want you to think about this. In the entire history of the world, since the dawn of mankind, 2/3 of all the men and women who have ever lived to the age of 65 are currently alive today.
And that's the world that we live in. And if you think about this next slide here, we live at a point in time when we use more medications per person, per capita, than at any other time in our history. And both of those statistics are increasing. So, we're going to share a lot of statistics. You've already heard some earlier. Statistics are a bit like bikinis. What you see is revealing, but what is hidden is vital, right? So embedded in these two statistics are the fact that what is hidden in plain sight is we have more seniors using more medications at a time when we're grappling with all the things that Susan mentioned about introducing technology and trying to transform practice models, as Mark mentioned, and get us to a point where we can transform out of a traditional fee-for-service practice model into something that's far more accountable. And yet we have this population that's really struggling with dealing with those medications. So like a good academic, I've come up with an equation that solves for this problem. So if you go to the next slide, my equation, kind of like Marie's, is that we have too many medications in many cases that are being used in a population that find them too complicated to use them. Oftentimes those medications are inappropriate, not intentionally inappropriate, but they're inappropriate. And importantly, they're not aligned with the patient's goals of care. And that definition is a hot mess. And that's what we're all trying to solve for, are these hot messes. Now, you can actually take this equation, and when it becomes a logarithmic problem, it becomes a dumpster fire. And there's a lot of those that are out there as well. And to Mark's point earlier, we shouldn't wait till we get to these hot messes. We want to try to solve these problems further upstream. It's a challenge, however, for us to be able to integrate that solution at a point where there's an opportunity for the pharmacist to engage meaningfully, find that there's compensation for that, and be able to coordinate that care across the system. So I also am reminded that at all times, drugs don't work in people who don't take them. That was C. Everett Koop's comment probably better part of 15 to 20 years ago. And at the end of the day, we can put in elaborate drone delivery services, but if the medications that get to somebody are not actually making it into their body, we have designed a system that ultimately fails. And that's what we struggle with, because I think we can see to a greater extent nowadays that there's a lot more insight that we have around med management and the problems that we have. But it comes down to the old fact that we have a human being in the middle. And Alexa could tell you to take your medications, but Alexa can't make you take the medications. So one of the challenges that we try to solve for is around that adherence issue, which I know Marie said is 20 to 30% of the challenge, but it's an important piece of the puzzle. So the big picture, and I don't want to belabor this because I think unless you've been living under a rock, you probably have heard that the challenge that we face is we can no longer afford what we've been doing in this country in terms of health care. 17% of our GDP goes towards health care. This is what the federal debt looks like right now. It's unsustainable. And as Mark alluded, here in Connecticut, just like every place else in the country, next slide, we're trying to move out of what has historically been the hamster wheel of fee-for-service into this value-based world where we have responsibility for the total cost of care. Within integrated care partners, that's something that we struggle with on a daily basis. How do we take the resources that we're getting in terms of value-based compensation for the care management that we're providing and disrupt the primary care model, disrupt the delivery of healthcare, and how does the pharmacist fit into that equation? So we are struggling to get out of this, out of what has historically been that fee-for-service. Next slide, please. And pharmacy is very similar to that, right? We have a challenge where we live in two worlds as well. On the one hand, we've got the reality that every patient needs a prescription, and we have a distribution chain to deliver that. And we have to keep that workflow operational because that's how we get the laundry out. Right now, that's how people are being reimbursed. But we want to evolve into that system where, as a nation, every health system, health plan, or grant, every person needs a pharmacist. They need their individual pharmacist to help them with managing this complex new world. So much like primary care practices are struggling to figure out how to reinvent themselves as payment models evolve, so too does pharmacy. We need to be thinking about how we evolve. And what's pushing us all to be focused on this is the tectonic drivers of quality and cost. And there's a myriad of different programs that are out there, this is a smattering of them, that are pushing us down this path of trying to identify the components of quality that matter and how those components impact cost. And I would argue that central to all of these quality programs out there, the biggest of them being the quality payment program by CMS, is that you can't succeed in this world if you don't know how to manage your medications properly. And I use that globally as far as being able to manage medications. So if we think about that equation I gave you about hot mess, let's just peel back some of the variables that feed into that equation. So the center there, it's a little hard to see, but it says potentially inappropriate medications and potentially inappropriate medication regimens. The variables that we struggle with is that, we have a challenge with identifying drug-drug interactions to the point, I forget whose slide it was now, about the secret shoppers that went in and identified that you could get this lethal combination of medications. We still struggle with being able to consistently deploy drug interaction screening or drug disease interaction. We have routinely people who are on medications that there's no indication for them. Maybe there was at one point, but there isn't now. As pharmacists, we add value to this equation by being able to use existing tools that are out there like Beers criteria or consensus guidelines of do not use medications to help tweak the equation on a hot mess and how to deal with that. We also can identify people nowadays more so through our data that may be at high risk of an emergency room visit. So we could help to channel them by looking for patterns of medication use away from the high cost delivery center to an urgent care center or to the Minute Clinic or to some other place where the problem can be caught more upstream. Next slide. As pharmacists, the other value that we bring to these equations is we recognize through the skill and training that everybody has when there's overtreatment of medications or overtreatment of conditions, or the potential when there's a drug that is now exceeding the value that you get, that risk equation that we all struggle with, the risk and benefit of a medication that, a dose is appropriate in one situation, but a little too much can be dangerous in another. And lastly, we as a profession, I think, are ideally suited to deal with these complex needs and to be able to interpret those needs at a patient level and translate that into a health system approach. So if we can go to the next slide. For those of you who have been around and seen my slide decks, you'll recognize this. This is where I, in my formative years, came to the first part of my equation, which is too many medications. We are often having patients receive medications for which they can't manage, and they end up with lots of medications at their house. This is one patient's medications. I visited his house early in my career, and it helped me to appreciate the challenges of polypharmacy in an older population. Again, getting towards the outcomes of quality and cost, this is a big monkey wrench in the quality and cost equation. And it's something that we can actually impact. And Vicki, to your point about med reconciliation, it's a challenge right now at best. We're struggling with I'd say the nascent days of EMRs and the interconnectability of electronic medical records, where for most of us, the first thing we want to do when we have to reconcile meds is hit the escape button. It's no longer acceptable for people to say, it's not my responsibility, I don't need to reconcile meds on every single visit. We're evolving to a point where the next step is going to be we can actually make a change and have that change be able to be synced across the entire med use process, through the community pharmacies, through the hospital, through the primary care, through all the different interchanges and adjudication of prescriptions so that the drug actually disappears from somebody's profile. Right now, that's a big lift. So in many cases, what we're left with are the last two slides. making decisions off of either fictional lists or non-fictional lists. I think we can all agree we'd much rather than be a non-fictional list that we're making healthcare decisions off of. So the importance of this is because when you try to reconcile medications, there's an incredible opportunity to streamline the drug use process and to make important inroads in terms of adherence. If we look at historical data about the number of prescriptions that actually get filled after you have an exchange with your physician, we know that there's certainly room for improvement, right? If you see the slide here, for every 100 prescriptions that get filled, maybe half to 70% of those actually go to the pharmacy to pick up the prescription. Once you go to the pharmacy, then maybe 48 to 66 actually come out of the pharmacy. First problem is getting to the pharmacy, and that could be where we have Uber or Lyft help you to actually get there, or perhaps your drone is going to deliver the medications, so that could be the disruptive change. But then you get down to the actual patient, the human challenge here, which is, are they taking it correctly? We've done all this work to get them to the point of it is the right drug for the right patient for the right time, but it's not being taken correctly. So I'm fortunate that I have a wonderful partner with me at Integrated Care Partners who's also faculty here at UConn. That's Christina Palomoff. And to try to put this in perspective, this is one of the patients that she saw. This is a gentleman that we identified through our care management program who was struggling with being able to manage his medications. She conducted a home visit, finds that he's very edematous. This is how he's managing his medications. They're strewn across his coffee table. His weight has gone up significantly. He has heart failure. They realize that he's not been taking his diuretics because they were lost in this sea of self-management here. And the intervention was to work with a care coordinator, with our pharmacy team, to get him back onto his diuretic, and in the course of a week, lost 30 pounds. We prevented him from having had potential heart failure exacerbation in an emergency room visit. That's the type of intervention that we are striving for. We would like to be able to say we do this on a routine basis for all the patients across the system. We're just not scaled right now to be able to do that. So we have to be selective in terms of who we touch, which kind of leads me to the next point, which is, we all want to do the right thing, but at times we have to make some difficult decisions, right? So to help us with making those difficult decisions, we're trying to the best that we can to use the data that we have available. I can't wait for the perfect data set to exist because I don't think it ever will. So we have to take what we have from our commercial payers. We take that claims information. We try to make the most sense of it from a pharmacy perspective. We build profiles that we can try to target the populations that we need. We are also trying to be prospective in looking at what we can do through our electronic medical records. We have 26 or more different EMRs that are in our integrated system, 3 big ones. And now we've launched another profile or product called Healthy Planet to help us coordinate across the continuum of care in the community. But it's a challenge, right? There's all these different system vendors that we have to navigate to try to get us to the point where we can solve the problems, which is how do we identify those high modifiable risk patients that Marie talked about? How do we move us on that curve to the point where the interventions are going to be really meaningful interventions and they're going to have a sizable impact, to Mark's point about getting us further down that value-based proposition and really managing at risk the total cost of care. So some of the pedestrian, truthfully, things that we're able to do right now, we can screen for those who are on 15 or more medications. I personally think that's a target-rich environment for us. There's a lot that we can do when we put a pharmacist in front of a patient who's got 15 or more medications. We can identify poor adherence, and we're being held accountable for that in some of our contracts as well. We look for high-risk medications and provide that feedback to providers. We look for people who have 2 or more falls and the meds that could have contributed to that. There's great evidence that shows that meds and falls go hand in hand. We can look for cognitively vulnerable populations who may struggle with complicated medication regimens, and again, connect them back into the care management team so that we have a better line of sight to people who are at risk of failing with their medication regimens. And lastly, and importantly, we look for those who are at risk for opioid dependence and abuse. And in particular, not trying to boil the ocean, looking for those who have benzodiazepines and opioids being prescribed at the same time. Part of what we're trying to do in our system is to take this information and now feed it back to our providers so we can be change agents. And we can see that there's an evolution in the practice. It's kind of the idea of you teach a man to fish. We're going to try to teach our primary care providers how they can change their own practice. So we're giving them feedback on high-risk medications. We're giving them feedback where they stand on their generic dispense rate so that they have some line of sight towards their impact on our total cost of care. And we're also working, it's not ready for prime time yet, but we're working on a way to surface an indicator of polypharmacy. You know, compared to your peers, do you prescribe more prescriptions than the average bear? You know, are you using more than somebody else with the same complexity, same panel size? And why is that? Is it because you're actually getting better outcomes? Or are you just raising the total cost of care and complexity unnecessarily? The way that we operationalize this is to try to combine this as a package. And we work very closely, I think one of maybe the earlier slides was that you need to be thinking about that continuum of care in your care management team. We work very closely with a group of nurses and social workers and coordinate our care throughout into two buckets of work. We have transitional care patients that come out of the hospitals that need an immediate touch and interaction, and they need to be made sure that they're safe when they go home and that they don't get readmitted. We also have another bucket of work around chronic care management patients. And it's that second bucket of work where we're perhaps better suited and skilled and scaled right now to be able to deliver those interventions. So working with our care management team, we identify these high-risk patients. We get pushed patients to us through the electronic medical record and our Healthy Planet platform. We also then prospectively find individuals that we're going to be looking for. That could be so the delivery of that care could be telephonic. We do telemedicine the old-fashioned way. We can pick up the phone and call a patient. We have yet to engage in any sort of video platform. But that's coming. You're right, it's coming. We can meet with a patient in a clinic. We could collaborate a visit with their provider. Or in some cases, we actually will go out and see people in their houses when we deem that that's going to be the most appropriate intervention for them. And then again, all that needs to be coordinated, documented, and shared seamlessly with the care team. Next slide. So I mentioned earlier that the things that are driving change, and I think where there's opportunities, the quality payment program, for us, we're spending an awful lot of time trying to understand the merit-based incentive payment system that is changing how physicians are being reimbursed for caring for Medicare patients. This has in it tremendous opportunities for pharmacists. And I would encourage you to look at the quality payment website. You can go in and look at all the different components that build into how physicians are going to be reimbursed. And you can search under improvement activities for medication management. You can search for pharmacists, and you'll see that there are areas that bring value to systems that have pharmacists and medications and medication management broadly encapsulated in there. And our CEO, Jim Carden, when we went through this exercise trying to figure out, what is ICP going to do as a solution for our members in our network, we came across the improvement activities and we saw that you can embed a pharmacist in the care management team, and his reaction was, great. We've got Sean and Christina. We've got 10 points on a medium-weighted quality metric that gets us a quarter of the way to our 40 points in our improvement activities, and it's all because we have a pharmacist. And I know there's a lot of numbers in there, but if you go into the care management platform, you'll understand why those numbers make sense. It's significant, and it's driving that value equation. So the last slide I'll finish with is, again, I bring this all back to where I began, which is you can have the best possible delivery model, you can have the highest trained individuals, but if you can't get down to the actual nuts and bolts of how our patients operationalizing themselves the medications that we're trying to get them to take, it falls apart. And this was driven home to me when I visited this gentleman who was struggling to manage his medications. I saw him first in the clinic, realized things weren't adding up, saw him in his house, and you can see that there's two Cool Whip lids here. The top lid is his reference Cool Whip lid in terms of how he sets his medications out every day. And he uses it as if it's a clock. So if I had the pointer here, I would say down by those pliers is about 7 o'clock in the morning when he starts to take his meds. You can see at 12 o'clock is his lunchtime meds, and then in the afternoon are his afternoon medications. And he sets a new Cool Whip lid out every single day. That's the reality of the hot mess that we deal with. We have patients that are trying to be very creative in struggling to manage the complexities of medications. I gave him a pill box. Didn't work so well. He went back to his Cool Whip lid. So what are the pliers for? Very good. Those are pill splitters. And if somebody said bottle opener, no, those are these pill splitters. And the gavel is pill crusher. Yes. Right? So I hope that you will keep that in mind as we redesign healthcare for the individual. And I guess I'll leave it at that. Thank you very much.
Well, I knew when I invited these folks to be speakers that they were wonderful speakers and very experienced speakers. I'm even more excited with our technology glitch that we're only like 2 minutes behind. So I told them that we were going to give Q&A, and we didn't have a chance to do that to catch up. But now we'll just take a few minutes into our break and do some Q&A for the panel. And because we are video recording, I'm going to repeat the question as well. So I see, Eric, you had a question.
So I have a sort of comment that maybe leads to a question. It's very sort of compelling, all the technology changes that are sort of coming down the pipe. And I've been in practice long enough where we've been talking about like technology, like there's a silver bullet that's going to come. And I'm just concerned that we get so focused on these sexy technology pieces. And there was a great book by Elizabeth Bradley, The Paradox of American Healthcare, where most of our healthcare outcomes actually are not what we spend on healthcare, it's all these other things. And I think Sean did a nice job of showing you like the sort of low-tech things that are the big problems. Are we sort of hanging too much on the technology that it's going to solve everything, not focusing on these other drivers of health outcomes? That's sort of the question that I have.
So I'll just rephrase it real quickly and shorten it a little bit, Eric, not to do justice to what your comment was, but the question around what's the balance or the tension between low tech and high tech. And let's start with Susan first.
Well, there's no question, and we know from decades of research that the fundamental drivers of health status in life lie entirely outside of the healthcare delivery system, right, by and large. We know that. I think that the piece that technology can help with, if you look at how some large systems are approaching this question, so for example, Kaiser Permanente with 12 million enrollees now nationwide, how can they use the technology, first of all, to identify the patients who are most in need of having those social issues addressed, right, which they can through analytics now. They can look at their, what sometimes are referred to as super utilizers. Turns out people don't like to be called super utilizers. So at Kaiser, they're called the vital few, but 1% of their patients are driving 20% of their costs, right? So they now have the analytics to be able to identify them. They can use low-tech means now to reach out to them and say, what are your social needs that we need to have addressed? And a system like Kaiser has the resources to then address them. Now, that's a challenge for the rest of healthcare, right, which doesn't look at itself as having necessarily any responsibility to address social needs, nor does it have the resources to address other social needs. And that's why you need the partners with the community organizations and everything else. But then let me just add one other tech piece to the equation. So Kaiser is on track, and by 2020, their total e-visits in the system will eclipse their physical visits because they've made so much investment in technology. And so you think about how technology could be applied to those situations we just heard about. Khan probably has a cell phone, right? She probably has a smartphone. As a member of the Kaiser system, she could be having video visits with somebody who could have helped her every day avert the disaster that happened. The fellow with edema, right? Kaiser is going to be enabled now to could have a daily video visit with that patient, could see that there were multiple medications in front, could basically be driven to do the med reconciliation that in this case only happened because somebody actually went out and saw the patient in the home, right? So I think the thing to think about is how technology is not going to solve these problems, but we do have new technological tools that if we use them and create the care models and the payment models that support them, it can get us way down the road to doing what we probably should have been doing all along, which is paying more attention to people as they live their lives, not in the healthcare system.
So we actually have time for a couple more questions, and our videographer says I don't even need to repeat them. The sound quality is so good. So if you speak up, another question? Tom.
So I'll just fill in the blanks there with Susan. Khan's actually been using video conferencing for 10 years, and we video conference with people in Cambodia, so we've been able to make that connection. We train folks that way. But I think to kind of get to Eric's point, the bridge with the social determinants of health, we find has to come through community health workers, and that's basically what Mark was talking about. So I guess my question would be is, I know I can't do my job without a community health worker, and how do you get these community health workers engaged into the system to be added into value-based payment mechanisms so we can address the social determinants and bring the technology together as well?
So Mark, do you want to comment on that?
Well, so Tom, thanks for that question. We have we've looked. Our practice transformation task force looked closely at that issue, and we believe that in the near term, the one relatively straightforward strategy is to provide upfront bundled payments that have an expectation of the implementation of team-based care models, including community health workers. And actually, with our CSIP program, we have an explicit requirement to integrate community health workers as part of this sort of, as a tool to succeed in a value-based payment environment, both to help with complex care need issues as well as chronic disease self-management issues. And so I think both if you can bundle E&M visits in primary care and you can add additional dollars to support additional team members, still holding them accountable for holding the line on total cost of care, you create the flexibility. You'll probably need requirements around community health workers, at least in the near term, so that they actually try to deploy those models, have an experience of success, and then I think you can loosen up. I think I also want to respond to the social determinants issue. One of the most common social determinant-related barriers we hear about is transportation. Transportation is largely a mitigatable barrier via telehealth, for example. But I've seen those pie charts that show 10% of the variance of sort of morbidity and mortality is accounted for through medical care, and the balances, environment, genetics, and behavior. And I think that there is an enormous opportunity to extract value for patients simply by better managing the vital few. The problem with today's, that pie chart that shows 90% living in these other areas, the problem today with even the most advanced HCP land Category 4 payment models is none of them reward a reduction in the incidence and prevalence of disease or injury. That is a problem to be solved. Today, there is no advantage financially in an accountable care arrangement to preventing your pre-diabetics from becoming diabetics. In fact, there is more of a financial opportunity if they're diabetics.
So we have time for maybe one more question, and then we'll take a quick break. Everybody wants a break? Okay, so we'll thank our great panel of speakers.